Welcome back to Stancoast NCLEX, your trusted platform where nursing knowledge becomes power and preparation turns into success. Here we post 2 to 3 advanced NCLEX videos every single day, filled with evidence-based content, clinical reasoning, and Stancoast pearls that make complex concepts simple, memorable, and exam-ready. In today's high-yield gastrointestinal session, we are focusing on nursing care of clients with disorders of the esophagus. This topic is crucial for both NCLEX and clinical practice, as disorders like gastroesophageal reflux disease, GERD, esophagitis, achalasia, hiatal hernia, and esophageal cancer are common yet potentially serious. In this lesson, we will explore the pathophysiology behind these disorders, their clinical manifestations, diagnostic procedures, and priority nursing interventions. You will also learn essential lifestyle modifications, medication management, and pre- and post-procedural care, including education for clients undergoing endoscopy or esophageal surgery. So stay tuned and follow along carefully, because this session will help you connect your understanding from physiology to patient care, the true mark of a competent nurse. And remember, at Stancoast NCLEX, we do not just teach for the test. We prepare you to care with confidence, compassion, and clinical excellence. Let's begin today's insightful journey on disorders of the esophagus. Hold on, don't skip this, because what I'm about to share could be the difference between passing and retaking your NCLEX.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get: 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now transition into another high-level NCLEX-style clinical reasoning question that explores pre-procedure client education and the nurse's role in promoting safe diagnostic preparation. A 60-year-old client reports difficulty swallowing and is scheduled for an esophagoscopy in the ambulatory surgical department. During the pre-procedure teaching session, which statement made by the client best demonstrates correct understanding of the preparation required for the procedure? Here are the available options for you to consider. Option A: I need to eat a light breakfast before the examination. Option B: I should consume a low-residue diet until the test has been completed. Option C: I need to avoid food and fluids after midnight before the test. Option D: I have to drink a quart of liquid before arriving for the test. The correct answer is Option C. I need to avoid food and fluids after midnight before the test. Now, let us thoughtfully unpack the rationale behind this correct answer. An esophagoscopy is a diagnostic endoscopic procedure that allows direct visualization of the esophageal mucosa to detect abnormalities such as strictures, varices, ulcers, tumors, or causes of dysphagia. The test involves inserting a flexible fiber optic endoscope through the mouth and down the esophagus, often under local anesthesia, with sedation. Because sedation depresses the gag and cough reflexes, there is a significant risk of aspiration if the stomach contains any residual food or fluids. Therefore, it is essential that the client remains NPO, meaning nothing by mouth, after midnight before the test. This ensures that gastric contents are minimized, protecting the airway during and after the procedure. After the procedure, the nurse must carefully withhold food and fluids until the client's gag reflex has returned, confirming that protective airway mechanisms are restored. The gag reflex is typically assessed by gently touching the posterior pharynx or observing for an effective swallow. Once verified, oral intake can be resumed safely. Let us also analyze why the other options are incorrect. To begin with, option A, I need to eat a light breakfast before the examination, is incorrect because even a small meal increases the risk of aspiration once sedation suppresses airway reflexes. No solid or liquid intake should occur after midnight before such procedures. Moving to option B, I should consume a low-residue diet until the test has been completed. This is also incorrect since a low-residue diet is used to prepare for colon examinations like colonoscopy, where bowel visualization is necessary. It is not relevant to upper gastrointestinal procedures. Lastly, option D, I have to drink a quart of liquid before arriving for the test, is inaccurate because this preparation applies to imaging tests such as pelvic ultrasound or certain urinary studies that require a full bladder. Consuming fluids before esophagoscopy would again increase aspiration risk. Now transitioning into the Stancoast clinical insight, before every scope that enters the airway, silence the stomach to safeguard the lungs. The NPO order is not a mere routine. It is an invisible shield against aspiration, one of the most preventable anesthesia-related complications. Moving forward to the Stancoast High-Yield NCLEX Pearl, keep the client NPO for at least 6 to 8 hours before an esophagoscopy. Always check the return of the gag reflex before offering any food or fluids post-procedure. Closely monitor for complications such as bleeding, dyspnea, or perforation, manifested by chest or neck pain, subcutaneous emphysema, or fever. And educate the client to promptly report difficulty swallowing, persistent hoarseness, or blood-tinged saliva after the procedure. Let us now move ahead to another advanced-level NCLEX-style clinical reasoning question that focuses on safe dietary teaching for a client with an esophageal disorder. A client recently underwent an esophagoscopy that revealed a stricture near the distal end of the esophagus. The nurse is developing a dietary teaching plan to help the client improve swallowing and reduce discomfort during meals. Which recommendation should the nurse emphasize to promote safe and effective swallowing? Here are the available options to consider. Option A says, eat a variety of foods containing a thickener. Option B says, thoroughly chew everything that is eaten. Option C says, avoid drinking beverages while eating a meal. Option D says, consume a full liquid diet. The correct answer is option B, thoroughly chew everything that is eaten. Now, let us explore the reasoning behind this. An esophageal stricture is a structural narrowing of the esophagus, often resulting from chronic gastroesophageal reflux disease, radiation injury, caustic ingestion, or surgical scarring. This narrowing impedes the smooth passage of food and increases the risk of dysphagia, regurgitation, and aspiration. The nursing goal here is to facilitate safe swallowing while maintaining adequate nutrition. Encouraging the client to take small bites and chew food thoroughly allows each bolus to become finely broken down and moistened with saliva. Saliva not only softens food, but also contains mucins and enzymes like amylase that initiate digestion and make swallowing easier. This technique minimizes the risk of food impaction above the narrowed segment and enhances both comfort and safety. Therefore, option B is the most appropriate recommendation to promote effective swallowing and prevent complications. Moving on to analyze the other options, let us understand why they are less suitable. Option A, eat a variety of foods containing a thickener, is typically useful for clients with oropharyngeal dysphagia, such as after a stroke, where aspiration risk arises from poor airway coordination. However, in an esophageal stricture, the issue lies below the pharynx, and thicker food consistency may increase resistance and obstruction. Option C, avoid drinking beverages while eating a meal, is actually counterproductive. Taking sips of liquid between bites helps propel food downward, clears residual particles, and reduces irritation. This strategy supports smoother swallowing and prevents food from sticking to the esophageal walls. Option D, consume a full liquid diet, might be prescribed temporarily after procedures like esophageal dilation or during acute inflammation. However, using this as a long-term measure without clinical indication can lead to poor nutritional intake and weaken the muscles involved in swallowing. It is more beneficial to focus first on chewing thoroughly and consuming well-tolerated soft foods. Now, transitioning to a deeper Stancoast clinical insight perspective for better understanding. When the esophagus narrows, patience becomes the nurse's most powerful tool. Encouraging small bites, slow eating, and thorough chewing turns each meal into a therapeutic exercise that keeps nutrition flowing and aspiration away. And now, let us reinforce this learning with some high-yield exam takeaways. Stancoast, high-yield NCLEX, Pearl. Always encourage small bites and thorough chewing before recommending diet modifications. Allow fluids between bites to help the bolus pass easily. Avoid extreme food temperatures and coarse textures. Post-procedure, assess for return of gag reflex and tolerance to soft foods before advancing the diet. If dysphagia worsens, promptly notify the healthcare provider. This could indicate progression of the stricture requiring further intervention. Moving ahead to our next advanced level NCLEX-style clinical reasoning scenario, let us examine a case that highlights the deadly complications of chronic liver disease. A 38-year-old client is admitted with bleeding esophageal varices and requires an urgent blood transfusion. As the nurse carefully reviews the client's medical record, the question arises: which factor is most likely related to this life-threatening condition? Here are the available options. Option A states there was a prior suicide attempt by ingesting lye. Option B says the client has a history of oral cancer. Option C mentions the client is a known hemophiliac. And option D indicates there is a history of chronic alcohol consumption. The correct answer is option D. There is a history of chronic alcohol consumption. Now let us unfold the detailed reasoning behind this. Esophageal varices are dilated and twisted veins located in the lower part of the esophagus, formed as a direct result of portal hypertension, which most commonly develops from liver cirrhosis. Chronic alcohol intake gradually destroys liver cells, replacing healthy hepatocytes with scar tissue and fibrous nodules. This scarring disrupts the normal blood flow through the liver, causing pressure to build up in the portal venous system. As this pressure increases, blood is diverted into smaller collateral veins, especially those in the esophagus and stomach, where it cannot safely flow. These veins expand and become fragile, and over time the increased tension leads to rupture and massive gastrointestinal bleeding. Clinically, this presents with hematemesis, melena, hypertension, and symptoms of hypovolemic shock. From a nursing perspective, linking chronic alcohol use to this pathology is vital for both acute management and long-term care. The nurse must anticipate emergency interventions such as endoscopic variceal ligation, EVL, octreotide infusion, and fluid or blood resuscitation, while closely monitoring for signs of shock and hepatic encephalopathy due to elevated ammonia levels. Now, let us break down the rationale for each option in detail. Beginning with option A, prior suicide attempt by ingesting lye. Although ingesting caustic agents like lye can cause severe esophageal injury, the resulting damage involves chemical burns and strictures, not vascular dilation. It leads to scarring and swallowing difficulty, but not variceal bleeding, making this option unrelated. Next, option B, history of oral cancer. While oral cancer involves the mucosal lining of the mouth or pharynx, it has no relationship with hepatic circulation or portal pressure. Therefore, it cannot cause varices. Moving on to option C, known hemophiliac. Hemophilia results from deficiencies in clotting factors such as factor 8 or 9, causing prolonged bleeding due to coagulation failure, not venous engorgement. Although such clients bleed easily, they do not develop esophageal varices. Finally, option D, chronic alcohol consumption, correct? Excessive and prolonged alcohol intake causes hepatic fibrosis and cirrhosis, leading to portal hypertension. The elevated venous pressure creates backflow and dilation of esophageal veins, which become prone to rupture and hemorrhage. Recognizing this relationship guides critical nursing actions and long-term health teaching focused on alcohol cessation, dietary control, and regular liver monitoring. Transitioning now to the Stancoast clinical insight. When the liver stiffens, the veins cry for relief. Portal hypertension forces blood into fragile detours, and the esophagus becomes its victim. A vigilant nurse recognizes that managing variceal bleeding is not just about stopping the flow of blood, but about protecting the failing liver that caused it. Finally, let us conclude with the Stancoast High-Yield NCLEX Pearl. Remember this simple link. Esophageal varices equals portal hypertension due to cirrhosis, most often alcohol-induced. Always assess for hematemesis, melena, and hypovolemia. Emergency treatment includes octreotide infusion and endoscopic variceal ligation. Never insert a nasogastric tube during active bleeding. It can rupture the fragile veins. And finally, the long-term nursing goal focuses on controlling portal pressure with beta blockers, alcohol abstinence, and evaluation for liver transplantation. Let us now transition smoothly into our next high-stakes clinical scenario that emphasizes patient safety and critical thinking during blood transfusion therapy. As part of a complex post-operative care plan, a registered nurse begins transfusing a unit of packed red blood cells to a client who appears pale, hypertensive, and tachycardic following abdominal surgery. The registered nurse then delegates the continuous monitoring of this transfusion to a licensed practical nurse. The question arises, according to the Joint Commission's National Patient Safety Goals, which nursing action ensures compliance with safe blood administration practices? Here are the options to consider carefully. Option A states that 2 nurses must review the blood bag and the client's identification band at the bedside before starting the transfusion. Option B suggests that a Foley catheter must be inserted to monitor urine output during every blood transfusion. Option C mentions that a 22-gauge intravenous needle should be used to prevent vein trauma. Option D claims that each unit of blood should be completed within 12 hours of initiation to prevent overload. The correct answer is option A. 2 nurses must review the blood bag and the client's identification band at the bedside before starting the transfusion. Now, moving forward to understand the reasoning in depth. The Joint Commission's National Patient Safety Goals, NPSGs, prioritize accurate client identification as a cornerstone of safe clinical care, particularly during procedures that involve blood or blood products. Transfusion errors are among the most catastrophic yet preventable medical events, leading to acute hemolytic reactions, shock, renal failure, or even death. To avoid such sentinel events, 2 licensed personnel, typically 2 registered nurses or 1 registered nurse and 1 licensed practical nurse, depending on facility policy, must jointly verify the blood unit and client identity right at the bedside, not at the nurse's station. This real-time verification includes matching the client's full name, hospital ID number, blood group, RH factor, cross-match compatibility label, and expiration date printed on both the blood bag and the client's armband. Performing this verification in the client's presence serves as the final checkpoint to intercept potential labeling or identification errors before transfusion begins. In the event of any mismatch, the blood must never be administered and should immediately be returned to the blood bank for investigation. Once verified, transfusion begins through a filtered blood administration set using only normal saline as the compatible fluid. The registered nurse initiates the process, while the assisting nurse, often the licensed practical nurse, continues to monitor closely, particularly during the first 15 minutes, which is the critical window for detecting early transfusion reactions. Transitioning now to understand why the remaining options are incorrect. Option B is incorrect, because inserting a Foley catheter for every transfusion is not a routine requirement. It is indicated only when strict monitoring of urine output is essential, such as in clients with acute kidney injury or shock. Routine catheterization increases the risk of catheter-associated urinary tract infection, CAUT, and provides no added safety benefit for standard transfusions. Option C is also incorrect because a 22-gauge needle is too narrow for transfusing blood, which may lead to hemolysis of red blood cells. Standard transfusion practice requires using a larger bore, typically an 18 to 20 gauge catheter, to facilitate smooth, unpressurized flow of blood components and prevent mechanical damage. Option D is unsafe as well. Blood products must be infused within 4 hours of removal from the blood bank refrigerator. Extending infusion beyond that duration promotes bacterial growth and increases the risk of septic reactions. Transitioning to a Stancoast clinical insight. Every drop of transfused blood carries a life, and one mismatched label can take it away. The double nurse verification is not just a rule, it is a sacred pause of safety before the Red River flows. Finally, let us conclude with the Stancoast High-Yield NCLEX Pearl. Always ensure a 2-nurse bedside verification that matches both client identifiers and blood compatibility details. Use an 18 to 20 gauge intravenous catheter with only normal saline as the compatible fluid. Begin transfusion slowly, reassessing vital signs every 15 minutes during the initial phase. Never infuse blood beyond 4 hours from initiation. If a transfusion reaction occurs, such as fever, chills, back pain, dyspnea, flushing, or dark urine, stop the transfusion immediately, maintain intravenous access with normal saline, and promptly notify the physician and blood bank. Let me share something before we jump in.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Shifting our focus to another critical care emergency, let us explore a scenario that demands rapid nursing judgment during a blood transfusion. A nurse is administering a unit of packed red blood cells to a post-operative client when, just minutes after initiation, the client suddenly reports chest tightness and shortness of breath. The client's blood pressure begins to drop, and tachycardia with restlessness are observed. The question arises, which assessment finding provides the best indication that a transfusion reaction is occurring? Here are the options to consider. Option A says the client's urine is very dark yellow. Option B states the client suddenly becomes dyspneic. Option C mentions that the client's skin is pale and cool. Option D suggests that the client experiences extreme thirst. The correct answer is Option B. The client suddenly becomes dyspneic. To understand this fully, let us expand on the rationale. A sudden onset of dyspnea during a blood transfusion is one of the earliest and most reliable signs of a transfusion reaction, particularly an acute hemolytic or anaphylactic reaction. In an acute hemolytic transfusion reaction, incompatible donor red blood cells are destroyed by the recipient's antibodies, releasing free hemoglobin into circulation. This immune-mediated destruction leads to capillary leakage, vasodilation, and bronchoconstriction, all of which manifest as dyspnea, chest pain, hypotension, tachycardia, and chills. As red blood cells rupture, hemoglobin is excreted in urine, resulting in hemoglobinuria that can cause acute kidney injury. On the other hand, an anaphylactic transfusion reaction triggers massive histamine release, causing airway edema, bronchospasm, and potential cardiovascular collapse. Because respiratory compromise is the earliest and most life-threatening clue, the nurse must immediately stop the transfusion, maintain intravenous access with normal saline, and promptly notify both the healthcare provider and the blood bank for further management. Now let us analyze why the other options are incorrect. Option A, the client's urine is very dark yellow, may occur later as hemoglobinuria develops, but it represents a late sign of hemolysis, not an early indicator. Waiting for this finding can delay life-saving intervention. Option C, the client's skin is pale and cool, is non-specific and may occur in multiple situations, including hypovolemia or post-operative shock. These skin changes do not confirm a transfusion reaction without accompanying cardiorespiratory findings. Option D, the client experiences extreme thirst, is also non-specific and often associated with dehydration or hyponatremia, not with transfusion-related immune responses. Before moving forward, let us pause for a key reminder under the Stancoast clinical insight. Transfusion reactions can begin silently but escalate within minutes. The moment a client shows even mild dyspnea, chest tightness, or anxiety during a transfusion, stop, assess, and act. The airway and circulation take precedence over completion of any unit of blood. Finally, let us conclude with the Stancoast High-Yield NCLEX Pearl. Always stay with the client for the first 15 minutes of a blood transfusion, as this is when most severe reactions occur. Stop the transfusion immediately at the first sign of distress. Never attempt to wait and see. Keep the intravenous line open with normal saline only, never dextrose or lactated ringers. Save the blood bag and tubing for the blood bank investigation, and document every observation and intervention precisely to ensure accountability and patient safety. Let us transition into this next advanced level NCLEX-style question that explores one of the most common gastrointestinal complaints encountered in community nursing practice. During a routine home visit, a nurse assesses a middle-aged client who reports discomfort that worsens after large meals and when lying down at night. The nurse suspects the symptoms may be related to gastroesophageal reflux disease, commonly abbreviated as GERD. Now, the key question becomes, Which symptom should the nurse identify as the client's chief complaint? Here are the options to consider. Option A says vomiting. Option B mentions nausea. Option C lists anorexia. Option D describes heartburn. The correct answer is option D, heartburn. Moving forward to the detailed rationale. GERD is a chronic disorder characterized by the backward flow of acidic gastric contents into the lower esophagus due to relaxation or incompetence of the lower esophageal sphincter. The most classic and frequently reported symptom of GERD is heartburn, also called pyrosis, which clients describe as a burning sensation that rises from the epigastric region toward the chest or throat. It typically appears after meals during bending or when lying supine. This burning discomfort occurs because the acidic gastric contents irritate the delicate esophageal mucosa that lacks the protective lining found in the stomach. Unlike cardiac pain, GERD-related heartburn often improves with antacids or by sitting upright, which distinguishes it from angina. Several precipitating factors can worsen reflux symptoms, including obesity, pregnancy, smoking, caffeine intake, alcohol, high-fat meals, and the presence of a hiatal hernia. Chronic exposure of the esophagus to acid can lead to complications such as esophagitis, Barrett's esophagus, or even esophageal adenocarcinoma. Therefore, early recognition of heartburn as the hallmark symptom is critical for prevention and timely intervention. Turning to why the other options are not correct. Option A, vomiting. Although occasional regurgitation of gastric contents may occur, persistent vomiting is not a characteristic feature of GERD. Instead, it may point to gastric outlet obstruction or peptic ulcer disease. Option B, nausea. While mild nausea can accompany reflux, it is nonspecific and not the primary indicator. It generally results from mucosal irritation or delayed gastric emptying after fatty meals. Option C, anorexia. Loss of appetite is unusual in uncomplicated GERD and is more suggestive of malignancy, gastritis, or advanced gastrointestinal pathology. Transitioning now to the Stancoast Clinical Insight. Heartburn is the language through which the esophagus cries out for protection. Recognizing that burning sensation as reflux and not dismissing it as indigestion can prevent years of silent mucosal injury. Moving forward to the Stancoast High-Yield NCLEX Pearl. Heartburn, pyrosis, remains the hallmark sign of GERD, especially when worsened by lying flat or bending after meals. Encourage clients to consume small, low-fat meals and avoid caffeine, chocolate, peppermint, alcohol, and late-night eating. Advise elevating the head of the bed by 6 to 8 inches and maintaining a healthy weight. If symptoms persist despite lifestyle changes, diagnostic testing such as 24-hour pH monitoring or esophagogastroduodenoscopy, EGD, becomes essential for confirmation. Let us smoothly transition into another clinically rich NCLEX-style scenario that tests both pathophysiology and client education. A middle-aged client reports recurrent episodes of burning pain in the chest and upper abdomen that worsen when lying down after meals. Until the physician can perform a full evaluation, which immediate suggestion should the nurse provide to help relieve the client's discomfort? Here are the options to consider carefully. Option A says to eat 3 well-balanced meals a day. Option B suggests eating foods that are easy to swallow. Option C recommends avoiding lying down after eating. Option D advises drinking clear liquids at room temperature. The correct answer is Option C. Avoid lying down after eating. Now, let us explore this in depth with an expanded rationale. Gastroesophageal reflux disease and hiatal hernia share a common underlying issue: the backflow of stomach contents into the esophagus due to relaxation or dysfunction of the lower esophageal sphincter. After eating, the stomach becomes distended, and when a person lies down too soon, gravity no longer helps keep food and acid contained. This reflux causes the familiar burning pain in the chest and throat, known as heartburn. By remaining upright for at least 2 hours after meals, gravity assists gastric emptying and prevents reflux episodes. Nurses should also teach clients to elevate the head of the bed by 6 to 8 inches during sleep using blocks or wedges, which further reduces nighttime reflux and improves rest. Additionally, clients should be encouraged to eat smaller, more frequent meals instead of large ones, since gastric overdistension increases pressure on the lower esophageal sphincter. They should also limit foods known to weaken sphincter tone, such as fatty, spicy, or acidic foods, caffeine, chocolate, alcohol, and carbonated beverages. Weight reduction and smoking cessation are critical long-term lifestyle changes because obesity and nicotine both increase intra-abdominal pressure and exacerbate reflux symptoms. Moving on to the incorrect choices, option A, eat 3 well-balanced meals a day, is incorrect because consuming large meals expands the stomach, raising pressure and worsening reflux. Instead, 4 to 6 small balanced meals are ideal. Option B, eat foods that are easy to swallow, is also incorrect, as this advice applies more to clients with swallowing disorders, not those with reflux. The type or texture of food does not directly prevent GERD symptoms. Option D, drink clear liquids at room temperature, is incorrect too, since temperature or clarity of fluids has little effect on reflux. However, it is best to avoid excessive fluid intake with meals and refrain from caffeinated or carbonated drinks that can worsen gastric pressure and relaxation of the sphincter. Before we move to our next learning point, here is an insightful Stancoast clinical insight. Gastroesophageal reflux disease management begins with gravity. Posture is your first medicine. Teaching clients to remain upright after meals is often more effective at night than medication alone. Moving forward to the Stancoast High-Yield NCLEX Pearl. Encourage small, frequent, low-fat meals throughout the day. Stay upright for at least 2 hours after eating to use gravity as a natural reflux barrier. Elevate the head of the bed while sleeping to reduce nighttime reflux. Avoid tight-fitting clothing, caffeine, alcohol, and nicotine that can weaken the sphincter. Promote gradual weight loss for long-term relief and improved esophageal function. Let us move ahead to our next advanced level NCLEX style question that focuses on client education and lifestyle modifications for gastroesophageal reflux disease. A 52-year-old client diagnosed with GERD reports experiencing worsening heartburn and regurgitation at night, especially when lying flat after dinner. The nurse reinforces teaching about lifestyle adjustments. So, which positional change should the nurse recommend to help minimize these nighttime reflux episodes? Here are the options. Option A suggests having the client remain supine on a mattress that contains a bedboard. Option B recommends advising the client to sleep on a waterbed temporarily. Option C proposes telling the client to elevate the legs on pillows when retiring at night. And option D advises the client to raise the head of the bed on 4-inch blocks. The correct answer is option D. Have the client raise the head of the bed on 4-inch blocks. Now, let us carefully understand the expanded advanced rationale. In gastroesophageal reflux disease, the lower esophageal sphincter does not close properly or relaxes inappropriately, allowing gastric acid and partially digested food to flow back into the esophagus. This reflux leads to heartburn, regurgitation, and discomfort, particularly at night. When the client lies flat, gravity no longer assists in keeping stomach contents in the stomach, worsening the reflux. By elevating the head of the bed approximately 4 to 6 inches, gravity helps prevent the upward flow of acid into the esophagus during sleep. This simple adjustment significantly decreases nocturnal coughing, choking, and aspiration risk. The nurse should teach clients to use sturdy blocks under the bedposts rather than extra pillows because multiple pillows flex the neck, increase intra-abdominal pressure, and may worsen reflux instead of relieving it. Moving forward to why the other options are incorrect. Option A, remaining supine on a bedboard, keeps the body flat, allowing gastric acid to flow easily into the esophagus, worsening reflux. A bedboard may improve back support, but has no therapeutic effect for GERD. Option B, sleeping on a waterbed, offers comfort, but does not prevent reflux. In fact, the fluid surface allows body sinking, which increases abdominal pressure and can aggravate symptoms. Option C, elevating the legs on pillows, improves venous return, but raises intra-abdominal pressure, forcing stomach contents upward and worsening GERD symptoms. And before we move to the high-yield insights, here comes the Stancoast clinical insight. GERD management begins with gravity. Positioning that supports the downward flow of gastric contents prevents acid from fighting its way up. The nurse's role is not just to medicate, but to modify lifestyle habits that keep the esophagus safe. Now, to wrap up with the essential exam-ready takeaway, here comes the Stancoast High-Yield NCLEX Pearl. Elevate the head of the bed 4 to 6 inches using sturdy blocks, not pillows. Avoid lying down within 2 to 3 hours after meals. Maintain a healthy body weight to reduce intra-abdominal pressure. Refrain from spicy foods, citrus, caffeine, alcohol, and late-night snacks. Stepping into our next critical thinking challenge, we explore a clinical question that emphasizes precise assessment in nutritional and metabolic management. A 75-year-old client with metastatic esophageal carcinoma is receiving total parenteral nutrition, also known as TPN, through a central venous catheter as part of palliative management. The nurse plans ongoing assessments to evaluate the client's response to TPN therapy. The question asks, which nursing assessment is most essential to determine how well the client is responding to this nutritional therapy? Here are the options for you to consider. Option A suggests testing the urine-specific gravity. Option B recommends monitoring the capillary blood glucose level. Option C involves measuring the arterial pulse pressure. And Option D advises obtaining an apical radial pulse rate. The correct answer is Option B. Monitor the capillary blood glucose level. Now, let us dive deeper into the expanded rationale to understand why this is the most essential assessment. Total parenteral nutrition delivers concentrated nutrients directly into the bloodstream, bypassing normal gastrointestinal digestion. TPN solutions typically contain high concentrations of dextrose, amino acids, electrolytes, vitamins, trace minerals, and lipids. Because these solutions are hyperosmolar and infused directly into the venous circulation, they can cause a rapid increase in plasma glucose levels. In elderly or palliative clients, such as this patient with metastatic esophageal cancer, the body's ability to metabolize glucose may be impaired due to stress-induced hypermetabolism, liver dysfunction, or concurrent corticosteroid therapy. Therefore, frequent monitoring of blood glucose is critical to evaluate metabolic tolerance and determine the need for insulin adjustment. When hyperglycemia occurs unchecked, it can result in osmotic diuresis, dehydration, electrolyte imbalance, and poor wound healing. Conversely, if TPN is suddenly stopped without tapering, rebound hypoglycemia can occur because insulin secretion continues despite the loss of glucose infusion. Moreover, elevated blood glucose may be an early indicator of infection or sepsis, particularly in clients with central venous catheters. This makes capillary blood glucose monitoring not only a measure of nutritional response, but also an early diagnostic clue for potential complications. Next, let us discuss why the other options are incorrect. Option A, testing urine-specific gravity, may provide information about hydration status, but does not directly reflect the client's nutritional response or glucose metabolism. Any changes in urine concentration from osmotic diuresis occur later and are non-specific findings. Option C, measuring arterial pulse pressure, offers insight into cardiac and vascular dynamics, but has no relation to TPN effectiveness. Pulse pressure variations typically result from cardiovascular changes, not metabolic nutrition therapy. Option D, obtaining an apical radial pulse rate, is used to detect pulse deficits in arrhythmias like atrial fibrillation. It has no direct relevance to TPN therapy unless an electrolyte imbalance causes arrhythmias, which would require laboratory, not pulse, monitoring. Transitioning now to the Stancoast Clinical Insight, Total Parenteral Nutrition transforms intravenous therapy into an artificial digestive system. But with this power comes metabolic risk. The vigilant nurse becomes the body's pancreas and liver at the bedside, watching, interpreting, and correcting what the body can no longer balance on its own. Now, moving ahead to the Stancoast High-Yield NCLEX Pearl, always monitor capillary blood glucose every 4 to 6 hours during TPN infusion. If TPN is interrupted, administer 10% dextrose to prevent rebound hypoglycemia. Always use an infusion pump for precise delivery. Never infuse TPN by gravity. Regularly inspect the central line insertion site for infection or air embolism. Monitor daily weights, serum electrolytes, and intake output to assess both fluid balance and metabolic adaptation. Moving ahead to our next clinical reasoning challenge, let us focus on a question that assesses the nurse's ability to interpret the most reliable indicator of nutritional improvement. A client is receiving total parenteral nutrition, or TPN, through a central venous catheter as part of nutritional therapy for severe malnutrition. The question asks, which finding documented in the client's chart provides the best evidence that the client is responding favorably to the administration of TPN? Now, here are the possible options for you to consider. Option A suggests that the client's electrolytes are in balance. Option B states that the client is gaining weight. Option C indicates that the client's appetite is returning. Option D mentions that the client is voiding clear yellow urine. The correct answer is Option B. The client is gaining weight. Let us now explore this scenario more deeply. Total parenteral nutrition delivers concentrated nutrients such as glucose, amino acids, lipids, electrolytes, vitamins, and trace minerals directly into the bloodstream, bypassing normal gastrointestinal digestion and absorption. It is prescribed when the gastrointestinal tract cannot be used effectively for nutrition, such as in cases of severe malnutrition, bowel obstruction, or during post-operative recovery. The nurse's foremost responsibility during TPN therapy is to monitor whether the client's nutritional status is improving over time. Among all measurable indicators, a gradual and consistent increase in weight is the most direct and reliable evidence of a positive response to TPN. A steady gain of approximately 0.5 to 1 kilogram per week reflects that the nutrients are being properly utilized, tissue stores are replenishing, and the client is achieving a positive nitrogen balance, a hallmark of effective nutritional recovery. Transitioning to the analysis of other options, let us understand why they do not represent the best evidence of improvement. Option A, showing that the client's electrolytes are balanced, simply reflects successful daily adjustments of the TPN formula by the healthcare team. While important for metabolic stability, it does not confirm actual tissue growth or nutrient assimilation. Option C, indicating a return of appetite, can be influenced by emotional, environmental, or medication-related factors, and does not necessarily correlate with the physiological recovery of nutritional status, especially since all nutrition is being administered intravenously. Option D, clear yellow urine, merely demonstrates adequate hydration and kidney function, which are managed by fluid balance rather than nutritional status. Now, before we move into the Stancoast insights, take note of this essential point. Weight gain over time remains the most meaningful sign of successful TPN therapy. Laboratory stabilization can occur quickly through careful adjustments, but true healing is reflected in the body's ability to rebuild tissue mass and store energy, seen as gradual, steady weight improvement. Transitioning now to the Stancoast clinical insight. Laboratory values can be managed by formula changes, but genuine nutritional recovery shows itself on the scale. A slow, consistent increase in weight signals that each infused calorie is rebuilding tissue, restoring strength, and renewing vitality. Moving forward to the Stancoast High-Yield NCLEX Pearl. Gradual, steady weight gain is the best indicator of TPN effectiveness. Weigh the client daily at the same time using the same calibrated scale. Monitor serum albumin and prealbumin levels to evaluate long-term nutritional status. Taper TPN gradually to avoid rebound hypoglycemia. Maintain strict aseptic technique with central line care to prevent catheter-related bloodstream infections, CLABSI. Before we begin, I want to share something that has already helped more than 100,000 nursing students achieve success.
If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete crash course.
Let us now transition smoothly into another clinical reasoning question that focuses on post-operative assessment and complication awareness. Imagine a client who has recently recovered from a cerebrovascular accident and is now being prepared for transfer to a long-term care facility. To meet the client's nutritional requirements, the physician inserts a gastrostomy tube. Immediately after this insertion, the nurse assesses the drainage at the new gastrostomy site. The question asks, which finding should the nurse interpret as normal during this immediate post-operative period? Here are the possible options for you to consider. Option A suggests milky drainage. Option B describes serosanguineous drainage. Option C mentions green-tinged drainage. And option D refers to bright, bloody drainage. The correct answer is option B, serosanguineous drainage. Now, let us dive deeper into the expanded rationale. Immediately after gastrostomy tube placement, a mild inflammatory process begins as part of normal tissue healing. During this phase, it is common to observe a small amount of serous, clear, straw-colored, or serosanguineous, slightly pink, drainage. This drainage represents a mixture of serum and a small quantity of red blood cells, indicating normal capillary oozing from the incised tissue. It is a sign that the healing process is underway. Such drainage should remain minimal, odorless, and gradually lessen within the first 24 to 48 hours. The nurse should continue sterile dressing changes and watch closely for any increase in volume, presence of pus, or bright red bleeding, all of which could signal infection or hemorrhage. Gastrostomy tubes provide direct access to the stomach through the abdominal wall for nutrition, bypassing the mouth and esophagus. Because this involves creating a new stoma, mild irritation and a small amount of exudate are expected. However, excessive, foul-smelling or colored drainage must always be treated as a red flag. Careful documentation of the drainage color, amount, and consistency helps detect complications early and ensures safe recovery. Moving on to the analysis of incorrect options. Option A, milky drainage, is incorrect because this type of drainage typically indicates infection or leakage of enteral feeding formula. Milky or cloudy output often appears thick and odorous, suggesting bacterial contamination. If noted before feeding begins, infection should be suspected and promptly reported. Next, option C, green-tinged drainage, is also incorrect. A green or bile-stained appearance means the drainage contains intestinal secretions. This is not expected from a stomach-level gastrostomy tube and may indicate tube migration into the duodenum or development of a fistula, which both require medical evaluation. Finally, option D, bright, bloody drainage, is clearly abnormal. Bright red or frank blood signifies active bleeding from an artery or gastric vessel injury. Once the initial minor oozing has stopped, such drainage demands immediate provider notification and preparation for emergency management to prevent hemorrhagic shock. Transitioning now to the Stancoast clinical insight. Before we wrap up, here is an important thought to guide your nursing judgment. Right after gastrostomy insertion, the body whispers recovery through light pink drainage, not through blood, bile, or milk. Recognizing what is expected protects the nurse from missing what is dangerous. Moving forward to the Stancoast High-Yield NCLEX Pearl. Always remember, small serous or serosanguineous drainage is normal during the first 24 to 48 hours after gastrostomy insertion. Abnormal findings include purulent, milky, bile-stained, or bright red drainage. Keep the dressing dry and intact, monitor and mark drainage on the dressing, and always assess tube placement, patency, and peristomal skin integrity to ensure safe recovery. Let us now move forward to another important question that focuses on clinical assessment and safety evaluation in post-operative enteral care. Imagine a nurse caring for a client who has recently undergone a gastrostomy tube insertion for long-term enteral feeding. During the initial post-operative assessment, the nurse begins to suspect possible tube migration. The critical question arises, which nursing technique provides the most accurate and non-invasive way to verify whether the gastrostomy tube has migrated from its original placement? Here are the options to consider carefully. Option A suggests testing the pH of aspirated gastric secretions. Option B recommends monitoring the results of a stomach X-ray. Option C proposes measuring the external length of the gastrostomy tube. And option D involves palpating the abdomen for distension. The correct answer is option C, measuring the external length of the gastrostomy tube. Now, transitioning into the expanded rationale, after gastrostomy tube placement, maintaining proper tube position is crucial to ensure safe delivery of nutrition and medications, while preventing life-threatening complications such as peritonitis, leakage, or aspiration. The most reliable bedside method for detecting tube migration is to measure and compare the external length of the tube from the skin at the stoma site to the tube's distal end at every shift or before each feeding. Each gastrostomy tube has a specific external length documented immediately after insertion, serving as a baseline. Any change in external length, whether an increase indicating outward migration or a decrease suggesting inward displacement into the duodenum, warrants immediate evaluation and possible physician notification. Although testing the pH of aspirated secretions can help distinguish gastric from respiratory placement, it is not reliable for gastrostomy tubes because these tubes are too short to reach the small intestine or respiratory tract. Moreover, medications such as proton pump inhibitors and continuous feeding can alter gastric pH, giving false results. While an X-ray remains the most definitive method to verify placement, it is not routinely used due to cost, radiation exposure, and impracticality for frequent monitoring. Finally, palpating the abdomen for distension may help identify feeding intolerance or blockage, but cannot determine tube migration, as distension can result from multiple unrelated factors, such as delayed gastric emptying or fluid retention. Therefore, measuring and documenting the external tube length consistently remains the nurse's most practical, accurate, and evidence-based bedside technique for ensuring correct placement and early detection of migration. Transitioning into a clinical wisdom highlight, here comes your Stancoast clinical insight. Tube migration does not always announce itself with obvious signs. Subtle changes in external length are your first warning. A vigilant nurse who measures consistently prevents silent complications before they become emergencies. And finally, moving to your Stancoast high-yield NCLEX Pearl. Always record the baseline external length immediately after insertion. Check and compare this measurement before each feeding or medication administration. Do not rely solely on aspiration or auscultation. Both are outdated and unreliable for placement verification. If migration is suspected, stop feedings immediately and notify the physician for further evaluation, possibly with imaging confirmation. Transitioning smoothly into our next clinical reasoning scenario, imagine a nurse preparing continuous enteral feeding for an adult client with a gastrostomy tube. The nurse fills the feeding bag with 2 cans of a commercially prepared formula, each can containing 8 ounces, and sets the feeding pump to deliver 120 milliliters per hour. The key question is, after how many hours should the nurse expect the entire feeding bag to empty? Now, moving on to the possible choices. Option A says 2 hours, Option B suggests 3 hours, Option C recommends 4 hours, and Option D proposes 5 hours. Shifting our focus to the conclusion, the correct answer is Option C, 4 hours. Correct answer, 4 hours. Let us now transition into the reasoning process in a detailed yet practical way. Each can of formula contains 8 ounces, and since 1 ounce equals 30 milliliters, one can provide 240 milliliters. Therefore, 2 cans equal 480 milliliters in total. Next, applying a simple but essential calculation, divide the total volume, 480 milliliters, by the infusion rate, 120 milliliters per hour, which equals 4 hours. This means the feeding bag will completely empty in approximately 4 hours. Moving beyond the math, let us explore the clinical importance. Understanding this calculation ensures not only accuracy in dosage, but also continuity in nutritional therapy. Any miscalculation may interrupt nutritional flow, delay medication schedules, or cause hyperglycemia if feeding runs too rapidly. Furthermore, consistent feeding timing helps maintain stable blood glucose levels and prevents complications such as dumping syndrome or intolerance. As we move to the nursing management aspect, remember that continuous tube feeding requires vigilant monitoring. The nurse should check gastric residuals, Observe for abdominal distension, nausea, or cramping, and ensure the tube remains patent. Flushing the tube with prescribed water volumes, typically every 4 hours, prevents clogging and maintains hydration. Additionally, it is essential to label the feeding bag with the time it was hung and the expiration time, since most formulas should not hang longer than 4 hours at room temperature due to bacterial contamination risk. Transitioning toward broader safety principles, the nurse should verify that the pump settings match the prescribed rate, document the initiation time, and replace formula and tubing every 24 hours as per policy. These actions promote infection control, maintain nutritional precision, and ensure client safety. Now, connecting this discussion to a real-world takeaway. Stancoast Clinical Insight. Accurate enteral feeding calculations protect both nutrition and safety. A miscalculated hour is not just a math mistake, it can mean a critical break in the client's lifeline of continuous nutrition. And to conclude with a quick exam-focused takeaway, Stancoast High Yield NCLEX Pearl. Always remember that 1 ounce equals 30 milliliters. To determine total infusion time, divide the total volume by the rate. Label feeding bags with both start and expiry times, maximum hang time 4 hours. Flush the tube routinely to maintain patency and hydration. And always verify pump settings at each shift to prevent overfeeding or underfeeding. Let us now transition into our next clinical reasoning question that sharpens your understanding of enteral feeding tolerance and safe nursing priorities. A client receiving continuous enteral feeding through a gastrostomy tube suddenly reports feeling unusually full, bloated, and mildly nauseated while the feeding is still infusing. The question is, what should the nurse do at this moment? Here are the options to carefully consider. Option A suggests measuring the gastric residual volume. Option B recommends administering an antiemetic through the gastrostomy tube. Option C proposes stopping the infusion temporarily. Option D advises adding sterile water to dilute the formula. Option E recommends turning the client onto the right side. And option F suggests requesting an order for a different type of feeding formula. After thoughtful analysis, the correct answers are option C, stop the infusion temporarily, and option E, turn the client onto the right side. Now, moving into the expanded advanced rationale, the client's complaint of fullness and nausea during enteral feeding suggests delayed gastric emptying or feeding intolerance. The safest and most immediate nursing action is to stop the infusion temporarily, as this prevents further accumulation of formula within the stomach, thereby reducing the risk of vomiting and aspiration. By pausing the infusion, the nurse allows the existing contents to move naturally through the gastrointestinal tract, which usually relieves discomfort. Next, the nurse should reposition the client onto the right side. This simple but highly effective maneuver promotes gravitational flow of gastric contents toward the pylorus, aiding faster gastric emptying. As a result, the client experiences less bloating and discomfort, without the need for additional medications or interventions. Although measuring gastric residual volume is important, it is not the first step during an acute episode of fullness or nausea. Residual checks are part of scheduled assessments, typically every 4 to 6 hours during continuous feedings. The current priority is to relieve discomfort and prevent aspiration. Administering an antiemetic may reduce nausea temporarily, but does not address the underlying cause, gastric overdistension. Similarly, adding sterile water to dilute the formula would worsen the problem by increasing stomach volume. Requesting a different formula is also premature. Such changes are made only after consistent feeding intolerance over 24 to 48 hours and after excluding factors like cold formula, rapid rate, or poor positioning. Before we move on to our key insights, here's a vital transition thought. Every symptom during enteral feeding is the body's message to pause, assess, and protect before proceeding. Transitioning to the Stancoast Clinical Insight. Enteral feeding is nutrition with precision. When the gut says stop, the nurse listens first. Pausing the flow and repositioning the client prevents aspiration, protects the airway, and restores comfort before complications begin. Now moving forward to the Stancoast High-Yield NCLEX Pearl. Always pause the infusion at the first sign of intolerance, such as fullness, bloating, or nausea. Keep the head of the bed elevated between 30 and 45 degrees during and after feeding. Resume feeding only once symptoms subside and tolerance is reassessed. Remember this principle always: safety first, stomach second. Up next, let us shift our focus to a vital question that strengthens your understanding of enteral feeding care and post-feeding safety measures. After the tube feeding formula has completely infused, which nursing action should the nurse take next to ensure safety and maintain tube patency? Here are your options to carefully consider. Option A suggests placing the client on the left side. Option B recommends lowering the head of the client's bed. Option C advises clamping the opening of the gastrostomy tube. And Option D proposes instilling several ounces of plain tap water down the tube. The correct answer is Option D. Instill several ounces of plain tap water down the tube. Let us now explore the expanded advanced rationale to understand why this is the most appropriate nursing action. Once a tube feeding has infused, the nurse's immediate focus shifts toward maintaining the patency of the feeding tube and meeting part of the client's daily hydration needs. The best intervention is to flush the tube with water. Typically 30 to 60 milliliters of plain tap water for clients with normal immune systems and sterile water for immunocompromised or critically ill patients. This step clears out any remaining formula that could clog the tube lumen, ensures accurate medication administration during subsequent doses, and contributes to the client's overall fluid balance. According to evidence-based enteral nutrition guidelines, nurses should flush the feeding tube after every feeding, before and after medication administration, and every 4 hours during continuous feedings. In addition, regular flushing helps prevent bacterial growth and biofilm formation that could lead to tube obstruction or infection. It also ensures accurate intake monitoring, an essential aspect of fluid management in clients receiving enteral therapy. Now, moving on to analyze why the other options are incorrect. Option A, placing the client on the left side, is not beneficial in this case because it may actually delay gastric emptying and does not reduce the risk of aspiration. The correct positioning both during and after feeding is a semi-Fowler's or Fowler's position, maintaining the head of the bed elevated between 30 and 45 degrees. Option B, lowering the head of the client's bed, is unsafe because it significantly increases the risk of regurgitation and aspiration pneumonia by allowing gastric contents to reflux into the airway. The head of the bed must remain elevated during the feeding and for at least 30 to 60 minutes afterward. Option C, clamping the opening of the gastrostomy tube immediately after feeding, is inappropriate if the tube has not been flushed first. Clamping without flushing allows formula to dry inside the tube, causing blockage and interfering with future feedings or medication administration. Transitioning now to your Stancoast clinical insight. Every milliliter of water used to flush a feeding tube is a silent protector, preventing clogs, maintaining hydration, and ensuring your client's safety with every feed. Finally, reinforcing this with a high-yield exam takeaway, Stancoast High-Yield Pearl. Always flush the tube with 30 to 60 milliliters of water after each feeding and medication administration. Keep the head of the bed elevated for 30 to 60 minutes following feedings to reduce aspiration risk. Use sterile water for critically ill or immunocompromised clients. And remember, never clamp a tube before flushing, because a few seconds of prevention can save hours of troubleshooting later. Moving forward to our next insightful scenario. Imagine a client with a newly placed gastrostomy tube who seems silent, withdrawn, and avoids eye contact while the nurse performs routine care at the insertion site. Now, in such a sensitive moment, which nursing statement would be the most therapeutic to encourage this client to express their feelings? Here are your options to consider. Option A asks, "Are you depressed?" Option B gently expresses, "It must be tough for you." Option C reassures, "This may get better soon." And option D normalizes by saying, "Lots of people eat this way." The correct answer is option B. It must be tough for you. Now, let us thoughtfully explore the expanded advanced rationale. When a client becomes withdrawn or silent after undergoing a body image-altering procedure like gastrostomy tube placement, it often signals deep emotional distress, anxiety, or a sense of loss related to self-image or independence. At this stage, the nurse's therapeutic priority is to foster a supportive, non-judgmental environment where the client feels emotionally safe to open up. The statement, "It must be tough for you," demonstrates empathy, validates the client's emotional struggle, and acknowledges their feelings without making assumptions. This empathetic approach builds trust and invites genuine communication, allowing the client to process complex emotions such as sadness, frustration, or embarrassment. By validating rather than minimizing these feelings, the nurse helps the client begin psychological adjustment and emotional healing, essential steps in recovery and adaptation to long-term care needs. Turning to the incorrect responses, option A, "Are you depressed?" may sound caring but is actually non-therapeutic because it is a closed-ended question that assumes a diagnosis and limits emotional exploration. Clients in emotional pain often respond with denial or retreat when directly questioned this way, further closing off communication. Meanwhile, option C, "This may get better soon," offers false reassurance, which can invalidate the client's feelings and reduce trust. It unintentionally conveys that the nurse is uncomfortable with emotional discussions. Lastly, option D, "Lots of people eat this way," tries to normalize the client's experience, but fails to individualize care. This response might come across as dismissive, implying that the client's emotions are less significant or exaggerated. Therefore, the best therapeutic statement is option B because it centers on empathy, validation, and reflective listening, the foundation of all therapeutic nurse-client relationships. Transitioning now to your Stancoast clinical insight, empathy opens the door to trust. When nurses validate feelings instead of fixing them, clients feel seen, heard, and safe enough to begin healing. And before we conclude, here comes your Stancoast high-yield pearl. Always choose statements that reflect and validate the client's emotions rather than offering advice or reassurance. Avoid closed-ended questions and false reassurance as they block emotional expression. Use empathy and therapeutic silence to invite communication. Acknowledge the client's emotional experience first, then move toward education or problem-solving once trust is established. Let us smoothly transition into this next high-yield NCLEX scenario, which focuses on home care management for clients with enteral feeding tubes. A client with a recently placed gastrostomy tube is being discharged home, and the nurse provides teaching to the family on what to do if the gastrostomy tube becomes obstructed. Now, which instruction should the nurse emphasize as the most appropriate initial action? Here are the options to consider. Option A suggests irrigating the gastrostomy tube with cola. Option B advises instilling sterile water with a syringe. Option C proposes milking the gastrostomy tube. And Option D recommends applying suction to the gastrostomy tube. The correct answer is Option A. Irrigate the gastrostomy tube with cola. Now, let us delve deeply into the expanded rationale behind this clinical decision. A gastrostomy tube may become obstructed due to dried formula residue, thickened medication particles, or inadequate flushing after feedings. When this occurs, the most effective first step at home is to use a gentle and safe method to clear the blockage. Cola or other carbonated beverages are effective because their mild acidity and effervescence help dissolve dried formula or medication debris without causing harm to gastric mucosa. The carbon dioxide bubbles loosen particles while the acidic nature breaks down congealed material, allowing smooth flow to be restored. This approach is commonly recommended in home and long-term care settings as a practical, evidence-based measure before considering tube replacement. However, caregivers must always perform this procedure gently with a syringe and never apply forceful pressure, as this may damage the tube or cause gastric injury. Moving ahead to analyze why the other options are incorrect, Option B, instill sterile water with a syringe, might initially seem safe, but it is not required because the gastrointestinal tract is not sterile. Warm tap water or carbonated beverage is preferred. While warm water can help soften debris, it lacks the dissolving power of cola when hardened formula or medications are the cause. Water alone is rarely effective once obstruction has occurred. Next, Option C, milk the gastrostomy tube, may sound practical, but it is often ineffective against blockages formed by thickened residue. Excessive manipulation can even damage the tubing or insertion site. This method can be used only gently and only after irrigation attempts have failed. Finally, Option D, apply suction to the gastrostomy tube, is absolutely unsafe. Applying suction can cause negative pressure injury to the gastric lining, collapse of the tube, or dislodgement of the internal balloon. Unlike nasogastric tubes, gastrostomy tubes are not designed for suction, and such practice can lead to mucosal trauma or bleeding. As we move to the key nursing takeaway, it is essential for nurses to educate caregivers that after every feeding or medication, the tube must be flushed with at least 30 milliliters of warm water to prevent obstruction. If resistance is felt, they must stop immediately and never force fluid through. When cola or warm water irrigation does not restore patency, the healthcare provider should be informed promptly for possible tube replacement. Now, before we wrap up, let us highlight a Stancoast clinical insight. Prevention is the nurse's best intervention. Every careful flush after feeding preserves patency, while every gentle irrigation restores a lifeline that upholds nutrition, comfort, and dignity. And finally, here comes your Stancoast learning gem. Always flush gastrostomy tubes before and after feedings or medications. Use warm water or carbonated beverages to gently clear mild clogs. Never apply suction or excessive pressure. Notify the healthcare provider if patency cannot be restored safely. Thank you for watching. We will see you soon in next video.